Ladies and gentlemen, dear friends and colleagues, my name is Michele Baccarani. I'm currently professor of hematology at the University of Bologna in Italy, and I am head of the Department of Oncology and Hematology at the hospital of this university. And I'm here to present on the recommendation which were made by a panel of experts appointed by the European Leukemia Network.
My name is John Goldman. I'm Professor of Hematology at Imperial College in London, and it's my task to talk a little bit about chronic myeloid leukemia and its response to a very dramatic new agent known as imatinib or Gleevec.
It is much more important to know very well what is imatinib failure, which corresponds to imatinib resistance. And look at the definitions that it has been given in the version 2009. A patient who does not achieve a complete hematologic response, that means blood counts normally and no palpable spleen in 3 months, is a failure.
Now, you mentioned about neutropenia as being one of the most common side effects, especially at the beginning of the treatment. Do you give other medications to offset the neutropenia?
Right, so neutropenia is common and it's usually seen in the first 3 to 6 months, and it tends to be a concern for 2 reasons. One, because doctors tend to stop the therapy, sometimes unnecessarily. Secondly, because it can be associated with an increased risk of infections. My personal experience is that patients who have a neutrophil count greater than 0.5 very rarely get into trouble. So I would not dose reduce, I would not stop therapy for any patient with a neutrophil count above 0.5.
I want to bring up 2 scenarios that are very difficult. One of them is those patients that have this mutation that I was just mentioning, this T315I mutation. And another scenario is those patients who have already failed 2 tyrosine kinase inhibitors. We know we don't have effective therapy for those patients, unfortunately, nowadays. I already mentioned that those are good candidates for transplant, but of course we know that not everybody can get a transplant. So there has been a lot of interest in developing new agents to try to help these patients that today don't have effective therapy.
We've had some very nice recent information that gives us further understanding about the importance of adherence for patients who are receiving imatinib for chronic myeloid leukemia. We see here, when we look at the probability of major molecular response in this very nice study from the Hammersmith group, in which they use a very sophisticated way to measure compliance using electronic surveillance that was contained within the actual pill bottle, so they could actually tell when a patient went to their pill bottle, when they didn't go to it. They found that, that there was a significant number of patients that had quite poor adherence.
And one can ask the question of whether this patient has actually been cured. But I think experience suggests that in most cases, if you stop the imatinib, transcripts will recur, and therefore you haven't entirely eradicated the leukemia, you've just suppressed it to a very low level.
One other approach that we're looking at when trying to improve the initial results for newly diagnosed patients is to use the new drugs that I just described, nilotinib and dasatinib, as initial therapy. And we have recently had the results of 2 very large randomized studies comparing directly nilotinib or dasatinib to imatinib.